Matin sir, please unmute yourself. Matin sir.
Very good evening all. On this eve of Akshay Tritiya, thank you all for joining and sparing time on this festival. I would like to also thank all your family members who allowed you to join on this festive eve. Today we are going for third session of protocols in pediatrics, and today's topic is neonatal jaundice. With this, I would like to request Dr. President Dr. Ram Gopal sir to please enlighten us with words of wisdom.
Good evening, friends. Thank you, Matin. Welcome all. Welcome to the third episode of Protocol in Pediatrics. As the name suggests, we take a different topic and we compare with different institution or maybe different bodies, what are the protocols they follows in the management of that particular. So today we are having a neonatal jaundice, and for that we are having two experts from the different institute, Dr. Sara Danaude and Dr. Amit Tagare. So welcome all. Over to you, Amit. We can start as early as possible.
Sir, I would like to request Dr. Amal sir, please to give enlighten us with words of wisdom. Amal sir, please.
Thank you. Thank you, Dr. Matin. First of all, welcome respected Mahesh Moite sir, Dr. Ram Gopal Chezara sir, Dr. Vikas More sir, Dr. Kundan Chopde, Dr. Sara Danaude madam. Today's expert, Dr. Neha Singh is there. Then Dr. Amit Tagare, neonatologist from Sangli, and all the delegates and PG students who have joined from various corners of Maharashtra and India as well. So, as the name suggests, as Dr. Ram sir has already told, this session is regarding the protocols, and one by one we are taking almost all the protocols which should be followed in various conditions in NICU, PICU, and in general pediatrics also. So today's topic is neonatal jaundice, and to enlighten about this we have Amit sir and Sara ma'am also. Another one important announcement today, Dr. Raigad IIP is arranging Mahanon this year in next month, and to tell us more about it, we have Dr. Mahesh Moite sir amongst us. So I request respected intensivist, a thorough gentleman and a great academician, Dr. Mahesh Moite sir, to tell us about Mahanon. Thank you. Over to you, sir.
Thank you, Amol, and thank you, Ramji, for giving me this opportunity. Can you run that teaser quickly? Somebody is holding that, right?
Hello, ma'am, please.
Hello, please play the video. Yes.
Thank you again, Dr. Amol and Dr. Ram Gopal and the organizers for giving us this opportunity. I'm sure most of you must be having those fresh memories of IIP or Mahapedicon in Prakriti Resort of Raigad, and that was in midst of COVID, and that was really a first big opportunity we had about 3 years ago. And now this is another big opportunity we are given to host this prestigious Maharashtra State Neonatal Conference, the Mahanon 24. So my team, led by Dr. Vikas More, who is actually a Raigad IP president, though I am a chairperson of this conference, upcoming conference. We are waiting for you. It's going to be on 22nd and 23rd of June, 2024. To make some specifications, we are really having a wonderful scientific program crafted. What I mean to say is going to be absolutely practical topics that we deal day in, day out. And just to name few, we have some tips for the survival of extremely low birth weight babies. There are some set and run a successful NICU. That's going to be very pick of the panel discussion led by, moderated by Dr. Ashish Mehta. Then what's new in PDA and probiotics and so many topics. They are going to be of practical utility to every person who is managing neonate or even those who are looking neonates or kind of managing neonates in their OPD as well. We have got our own all stalwart state faculty. Plus, we have few from the national level, as I already mentioned, Dr. Ashish Mehta from Ahmedabad, Dr. Naveen Jain from Kochi, Dr. Srinivas Murki is coming from Hyderabad, and there are few more. So we are eagerly waited not only to visit for this conference, but there are few new things. Really, you must have seen Raigad is having a wonderful blend of rural and urban, and you've seen our teaser, which has mixed up both so well. But I'm sure those who have not seen and traveled on the Atal Setu, that is one of the best wonders of this country. And we are eagerly awaiting you for attending this conference and enjoying our hospitality. So do register fast. We are sending those links for registration in all the groups. Those who are not getting it, they can call me directly or they can call my colleague, Dr. Vikas or Dr. Neha Singh. And please register fast. We have just exceeded our early bird. You can talk to us directly for any further assistance. Thank you very much again, Madam Happy, for giving us this opportunity to make the people aware of this conference. Thank you very much. The dates again, 22nd and 23rd of June, 24. Thank you very much. It's Mahanikon 24. Thank you very much.
You're most welcome, Mahesh sir, anytime on MyIP platform. I quickly request Dr. Vikas More sir. Is he there?
Yes,
Vikas,
he's
please,
there.
quick appeal.
Yes, as Mohite sir has mentioned, we are awaiting all Maharashtra members and IIP members from all over India to come for this prestigious conference. We are very fortunate to organize this wonderful academic conference, and we will be so happy to invite you to serve you here, and you will definitely enjoy the academic feast and also with a Raigad and Navi Mumbai flavor. Thank you so much, Mahapi, Ram sir, and Amol for giving this wonderful opportunity. Thank you.
Thank you, Vikas sir.
And our NNF secretary, Maha Secretary, Dr. Amit Tagare, he is also part of organizing team, and he is he can also invite you for this conference.
Right, Vikas sir. Now I hand over the baton to Dr. Matin, who is a young Maharashtra IIP Executive Board member from Sangli. So to you, Matin, please.
Thank you for the kind and best luck, Dr. Mohite sir and Vikas More sir for the nomination. We'll definitely register and I will inform this message to all. Going further, with today.
Matin, just I appeal all the branch office bearer to send the information to their respective branches so that the people can take advantage and can register for the conference.
Yes.
Yes, yes, sir. Yes. With this enlightening word, I'd like to share today's our first speaker, Dr. Sara Dhanode Madam. She is a Dean of Bharati Vidyapeeth, Dean to University Medical College and Hospital Sangli, and also a Professor of Pediatric. Her specialties, areas of special interest are neonatology, pediatric intensive care, infectious diseases, and medication. She has a very wide teaching experience. For UG, she has 37 years, and for PG teacher, she is 32 years. She has 32 years of PG experience. She has more than 30 publications, has contributed in various books, especially Stark's textbook of Pediatric second edition, and also Suraj Gupta's Recent Advances. She has received various awards, and she has received Asia Women Health Leader Award of Pediatrics 2022, Best Teacher Award from Bharati Vidyapeeth Pune in 2016, awarded Gold Medal for Best Intern in CMC. She is a trainer of IEP NRP Joint National Coordinator and co-editor of IEP PG teaching module 2018. National Tuberculosis Regional, she is a regional trainer. She is programmatic development for drug-resistant tuberculosis and trainer. Our second speaker, second expert is Dr. Amit Tagare sir, who himself is a renowned neurologist in our Sangli city. He has completed a DNB, MD, and DCH, and also DNB neonatology. Sir is a neonatal fellow from Australia. At present, sir is director and in charge neonatologist at Rainbow Super Specialty Children's Hospital, Sangli, Maharashtra, and also has joined Bharti Hospital recently. Special area of interest for Amit Tagare sir are neonatal parental neonatal nutrition, non-invasive ventilation, neonatal nursing, and neonatal sepsis. Sir has more than 15 publications in renowned reviewed journals. He has various chapters in different textbooks of neurology. He is a co-author of Neonatal Parental Nutrition Guidelines 2010. He is a faculty at various national and international conferences, and rightly he is the secretary of Maharashtra State Chapter NNS 2024-25. With a short introduction of both experts, I'd like to hand over further session to Dr. Amit Tagare sir and Dr. Janode. Please. Dr. Amit Tagare sir, will you please share the screen?
Is it visible?
Yes, sir. Your screen is out. Yes, sir, please.
Screen is still?
No, sir, not yet. Yes, it is visible right now. Yes, please proceed, sir.
Sure.
Screen is visible, sir. Your PPT is visible.
Sure. Good evening. I'm very thankful to Maharashtra IIT for giving us the opportunity to talk something about neonatology. Along with Raigad IIT, I'm very thankful for giving an opportunity to share about Mahanon. As you have seen the teaser, it will be a wonderful conference under the guidance of Mohite sir and the able leader as Dr. Vikas More. So we expect to see all of you on 21st and 22nd of and 23rd of June. We have multiple workshops also for those who are interested to attend. So now I will go ahead with today's topic, that is management of neonatal hyperbilirubinemia. Now, many of us will wonder why we are talking about neonatal hyperbilirubinemia, which is a very simple topic. But the most important thing is this is the commonest disease of neonate that a practicing pediatrician sees, and it's the commonest disease that is treated or managed by any pediatrician. So this is a wonderful thing by Maharashtra IIP about discussing the protocols, or what we better call guidelines, because protocol is a very harsh word, but at least guidelines. So NNF had taken a wonderful thing for giving guidelines for neonatology in India 15 years back, when it was the first CPG in 2010, and then they updated quite a few CPGs in 2020. So this is a clinical practice guideline for hyperbilirubinemia. Now, what is the aim behind this guideline? So the aim is to improve the quality of care and outcome of preterm and term infants by providing recommendations on screening, prevention, and management of hyperbilirubinemia. Now, why are we discussing it here? So who is the target audience? We all are target audience. It may be a neonatologist, it may be a pediatrician, you may be an obstetrician, because many times we provide phototherapy in obstetric hospitals, medical officers, nurses, and other practitioners. Who is the population of interest? The guideline focuses on screening, prevention, and management of hyperbilirubinemia in neonates admitted to healthcare settings. So we are the people who is the target audience, and our patients is the population of interest. And being the commonest, one of the commonest pathologies or issues that happen in managing neonates, we will discuss this in a bit detail. So, what is the incidence of hyperbilirubinemia? 60 to 80% of neonates in first week of life have hyperbilirubinemia. So it's a very common disease, more common in preterms than full terms. Significant number of the babies need treatment, what we call pathological hyperbilirubinemia. So the other one is the developmental or physiological hyperbilirubinemia. Now, most of the babies have benign. We all know. Many times relatives say, okay, we don't want to treat, but still nothing goes wrong. But the red flag is untreated severe hyperbilirubinemia, what we call more than 20 conventionally. We will see more about the scientific definition, can lead to bilirubin encephalopathy. So it can be acute bilirubin encephalopathy, that is stage 1, 2, 3, and the fourth stage is the dreaded one that we always fear of, is connectors, which is called chronic bilirubin encephalopathy. So we all try here to avoid bilirubin encephalopathy. So what are the causes of increased incidence in India? Now we have inherent racial and genetic factors like G6PD. Then India is a mixed population. Quite a few communities have high incidence of intermarriages. The serum albumin content of many of the Indian babies at birth is low. And we all know that albumin binds the bilirubin and reduces the free bilirubin. And what is damaging is the free bilirubin. So our babies tend to have higher amount of free bilirubin at the same level of bilirubin than the Caucasians. We all are suffering this summer. We all are facing hypernatremic dehydrations. We all are facing very high levels of bilirubin. So our prolonged summer causes dehydration because of improper feeding. So many times the feeding is not guided. Nobody monitors the thing. Nobody monitors the urine output, and the babies lose a lot of weight. And this dehydration increases the hyperbilirubinemia. Blood group incompatibilities are pretty common in India. In certain parts of India, RH is very high, like regions like Punjab. Infections are pretty common. Infection itself can cause hyperbilirubinemia. Infection increases the permeability of blood-brain barrier. So at same level, the bilirubin becomes more toxic for an infected baby. And the last and the most important is the ignorance. It's a lack of knowledge and awareness amongst the family members, even among the health workers. Many times it's like the weight is lost, babies look yellow, and we don't even bother to check the bilirubin levels. And this might lead to diagnosing it at a very late level, where it is a very high level of bilirubin, and usually some damage has already happened. Now, when to start? Now we will go. This guideline is very simple. Here we are checking only the practical questions. We are not going into any theory of hyperbilirubinemia because this is a clinical practice guideline. So it is to help every one of us to manage our patients. So we are dealing only with the questions that we feel practical. So when to start phototherapy among term and preterm neonates with hyperbilirubinemia? We all know we had that famous grading where we clinically assessed jaundice, and then we said, but after some time, you need a specific guideline. Now, in new this guideline is the AAP guideline, which is for more than 35 weeks babies. It's not applicable to less than 35 weeks babies. So it's more than 35 weeks babies. We have chronological age in hours. gestational age, and presence or absence of risk. Now, when we take the bilirubin level, we take the bilirubin level as a total bilirubin. We are not going to cancel that conjugated bilirubin and take into consideration only unconjugated bilirubin. Now, what are the risk factors? Risk factors are those which can increase the possibility of neurotoxicity. Now, it can be isoimmune hemolytic disease like Rh incompatibility, ABO incompatibility. It can be G6PD, where there is sudden gush of hemolysis and there is sudden rise of bleeding. Asphyxia, which increases the permeability and increases the chances of more damage. Significant lethargy, temperature instability, sepsis, acidosis, and as we have seen, lower serum bilirubin levels. Now, this is the AP chart. Now, when we say this is the bilirubin level in milligrams per deciliter, now this is the age, and if you see, it's marked in hours for first 5 days. Why it is hours? See, for day 2, it still can be 25 hours. It still can be 47 hours. Now I take a level of bilirubin in, assume a very low risk baby. Now the bilirubin level is assume 9. Now 9 at 25 hours is a risk and 9 at 47 hours is not a risk. That's why it is age in hours. So when we talk about bilirubin in first 5 days, we talk about age in hours. And we have the 3 lines. Now what are these 3 lines? The highermost line is the infant at low risk, that is completed 38 weeks. Now when it comes to hyperbilirubinemia, we have term that is more than 38 weeks complete. It's not 37 weeks. So complete 38 weeks or more without any risk. A well baby. Now, a same baby who is more than 38 weeks, but he has a risk factor, those risk factors that we discussed, or this is a baby who is between 35 weeks to 37 weeks, 6 days, and well. So it becomes a medium risk. And the higher risk patient is a baby who is a 35 weeks to 37 weeks, 6 days with a risk factor. So it is a lower level which damages a high risk baby. And for same level, a low risk or medium risk baby will not suffer. And that's why whenever we define hyperbilirubinemia scientifically, which is always as per this chart. So we can't just say, okay, bilirubin of 14 and baby is 5 days old, 4 days old. We should speak more scientifically. Like this bilirubin level, this baby is on this level, like low risk, middle risk, or higher risk at these hours of life. So that will give a more clear risk to the baby. Now, the additional factors to be considered among Indian neonates include higher incidence of G6PD, which needs to be diagnosed by lab. We can't just diagnose it. SGA neonates. Now, we are slowly coming up with delayed cord clamping, which is a very useful thing. It's protective, it's neuroprotective, it increases reduces the incidence of anemia and transfusions. But it will have higher volume of blood and that will have higher bilirubin level sometimes. Among neonates less than 35 weeks, we have measles ratio or nice guy. So it is not considered, it is not seen on the same chart because this chart is for more than 35 weeks. Now, what is the role of TCB? It has become very common, transcutaneous bilirubinometry, and it is almost available in all medical colleges and all NNF accredited level 2, level 3 centers, teaching centers, transcutaneous bilirubinometry is available. It's a very handy thing. It's a non-invasive thing. We can check the bilirubin in matter of moments. The TCB value is important to decide. It's a screening tool. We usually don't treat on TCB. It's a screening tool. So it will tell which baby I need to check below. So if the value is is within around 3 milligrams, 2.9 milligrams of the level in the previous chart, then we check the bilirubin and then if needed, we start the protocol. or consider the extreme stress. Now it's a very important thing, very popular full-time breast milk jaundice. Now, when it comes to breast milk and jaundice, there are two types of jaundices. It's one is breastfeeding jaundice. Now, breastfeeding jaundice is what happens in first few days of life, where there is less feeding, less calories, and that increases the bilirubin level. And the other thing is that prolonged jaundice, where it is assumed that some factor in breast milk causes jaundice. Now, it's pretty common practice still today. Many people advise to discontinue breastfeeding. The guideline says it is not recommended. Now, there are two things. One, breastfeeding will help in caloric content and it will help in the reducing intrahepatic circulation of bilirubin and more excretion of bilirubin. Now, when we start phototherapy, it is just isomerizing the bilirubin and making it more water soluble, which will go into the intestine and or in the urine and will be excreted. Now, unless we excrete it out, phototherapy won't work because that bilirubin might come again back into the circulation through intrahepatic circulation. So one benefit of breastfeeding is that, and the other thing is we are actually harassing the mother by a moral challenge that your milk is causing jaundice. Now this is a moral challenge, and the mother will have some issue that my milk is dangerous for my baby, and that is not good. And that's why recommendation says no, uh, don't discontinue breastfeeding for jaundice. All attempts must be made to rule out other causes of jaundice, which are actual causes of jaundice. Phototherapy should be started as per guideline, and mother should be provided lactation support and counseling for exclusive breastfeeding as per the infant and young child feeding guideline. Prophylactic phototherapy, RH incompatibility, ABA incompatibility, higher risk of jaundice, we have seen. Nothing in neonatology is prophylactic. So it is not recommended, assuming that this baby will develop jaundice, a preterm baby or a full-term baby with risk factor, he might develop jaundice. We'll start phototherapy. Will it work? It won't work. So prophylactic phototherapy is not recommended. Now, the important thing is we need to start phototherapy. Now, should we admit all the babies to NICU? The idea is if we admit all the babies to NICU, it will separate the mother and baby. In that case, the bonding between the mother and baby in this critical time of life that will help to develop breastfeeding will be active. So all those stable neonates with no other morbidity, where you can monitor them in maternity wards or in the mother's room, it is advised to keep the babies with mother in the room. Mother should be reassured that short breaks for feeding or diaper changing or cuddling the baby when he is crying is not going to affect the management of the jaundice. Single or multiple. Now, the basic idea is doing intensive phototherapy. Now, intensive phototherapy is the dose of phototherapy which is lying somewhere between 30 to 50 micrograms per square centimeter. So that intensive phototherapy you can give with a good single phototherapy unit. Otherwise, if you feel that your phototherapy is not giving enough dose, then we can add multiple phototherapies like two phototherapies or one more surface. Now, when we are putting surfaces, then many times it is given from the lower side also. The idea is to expose more surface area of the baby to receive more dose of phototherapy. Now, in that case, we can't make the baby lie on the plexiglass on an uncomfortable, very cold surface. So here you should either have some translucent sheet that will allow the phototherapy to come, or you can have a phototherapy blanket. But the idea is you should have a good phototherapy unit, or you check the dose, and if you feel it is not enough, then you can add two or three. But monitoring when it comes to these number of phototherapy is very important. So we need to monitor these babies because now everything is blue and it becomes very difficult to assess the hemodynamics. IV fluids. Do all babies with phototherapy need IV fluids? No. IV fluids routinely in management of jaundice, neonatal hyperbilirubinemia is not recommended. It is recommended only when we have severe dehydration or we are closing exchange transfusion. Here, what the idea is, by giving enough fluid, we increase the urine output, and once again, as we have discussed, it will help in excreting the water soluble bilirubin, and it will help in rapid drop in bilirubin. So IV fluid routinely for all babies under phototherapy is not. Changing position, as we have seen, surface area. So many people feel that if we keep on keeping sometimes for prone, sometimes for lateral, so more area will be exposed to phototherapy and it will help. It is not. Let the baby lie, whatever is comfortable position for that baby. Don't disturb it unnecessarily. Because anyway, under phototherapy, the baby is irritated because of that blue light. So, routine, periodic changes of position is not. Continuous or intermittent. Now, this is a hitch. Sometimes parents say, okay, we will come for some time and give phototherapy. Sometimes we feel that okay, we have only one light and we have two babies. So for some time this baby and for some time the other baby. The recommendation is continuous phototherapy, except for the interruptions which are routine interruptions like breastfeeding, nappy changes, or the baby is crying and the mother wants to cuddle the baby. So these are the only interruptions. We can't give interrupted phototherapy, 2 hours on, 1 hour off, 3 hours on, 2 hours off, something like that is not. Now, frequency of serum bilirubin. This is very critical, especially when we are having a sick baby close to transfusion, exchange transfusion. Now, when there is close to exchange transfusion, we need to measure it 4 to 6 hourly, sometimes even 2 hours. Because the recommendation says when we have a baby who is close to exchange level or at exchange level but neurologically normal, we start phototherapy and measure the bilirubin. If the bilirubin starts falling in an intact baby, intact neurology, then we just continue phototherapy and avoid it. But here we need to monitor it stringently. Now, how long? Once the baby is out of exchange threshold, then we can be lenient and we can measure it 8 to 12 hours. Or sometimes when it is lower side, it can be even in once in 24 hours. A follow-up serum bilirubin after discontinuation of phototherapy is done at 24 hours in a normal baby without any risk. And if there are features of hemolysis, then we can have two samples. Why? This is to see the rebound. Now, what is rebound? Whatever amount of bilirubin is there in the body that gets stored into the adipose tissues. And once we stop phototherapy, that thing can start coming out in the circulation, and then we will see the stored amount or the hidden amount of bilirubin, which is the rebound. So this rebound will be more in case of hemolysis because the bilirubin source is continuous. Now we have seen TCB is a good non-invasive screening tool. Now what we have seen that so many so frequently we might need to do bilirubin levels. So what about TCB in phototherapy? Now once we start phototherapy, TCB becomes unreliable. So monitoring of babies under lights with TCB or even after 24 hours stopping phototherapy is not reliable. So if we want to check once we intervene with phototherapy, it will be serum bilirubin. IVIG for RH or ABO incompatibility. Now IVIG was pretty commonly used for RH or ABO incompatibility to reduce hemolysis. But and many times it was used prophylactically, but most of the times it was therapeutically. But nowadays it is not recommended. So at this moment we don't recommend routine IVIG use for hemolytic jaundice. When to stop phototherapy? We have seen when to start phototherapy. Now anything that we start should be stopped. So what is that time? A phototherapy can be stopped when the TSB level is at least 3 milligrams per deciliter below the threshold. So whatever is the threshold. Now if the threshold for that age comes to around 18, and once it goes below 15, we can stop. A single value below threshold is sufficient for a normal baby without any risk factor. For baby with risk factors like hemolysis and all that, we can have two samples showing that it is below the level. Albumin before exchange, we have seen the albumin is the binder of bilirubin, and it will reduce the free bilirubin, so it will help in reducing toxicity. At the same time, the concept was if we give albumin, then it will bind the bilirubin, and in exchange we will remove that albumin, which will have a lot of bound the bilirubin, so it will reduce the total bilirubin, but that is not recommended. Now, the national guideline, the CPG, doesn't talk about the exchange transfusion, but I am just putting the same continuation of exchange transfusion because exchange transfusion, though nowadays we don't do it very commonly, it's very rare phenomenon. Actually, we feel like needing exchange transfusion is not good for the reputation of the unit, but that says that your phototherapy is not good. So, but a few times we need like hemolysis or sometimes when the babies come late. Now, as we have seen for the phototherapy charts, the same AP chart, but this is for exchange. It is same. On the y-axis, we have this bilirubin level in milligram per deciliter. On this x-axis, we have the age in hours, till 5 days, and then in days. We have the same three lines: low risk, medium risk, high risk. And this is the level. Now you can see the levels are a bit higher side. Now for a normal baby at 36 hours, even 16 becomes an exchange. But the same level, when we check at 25 hours, it becomes, sorry, for a high risk baby, it becomes 16 as the exchange level. And at 96 hours, it becomes 19 and 18, and it becomes steady by that time. For a normal baby, with a low risk baby, at 36 hours, 21 is the exchange. So 16 will be phototherapy, not exchange. For same age, same level, but different risk factors. Thank you.
Hello.
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 Yes.
Matin, hello.
Yes, ma'am. Please, Dhanodam, please tell me.
Yeah. Thank you, Amit,
Yes.
for that wonderful presentation. I have a couple of comments to make. Amit has done a wonderful presentation. Just I want to highlight that the American Academy has come out with the recent guidelines, that is 2022 guidelines, which recommends universal pre-discharge bilirubin screening. I don't know how many of us practice it, but definitely because after normal delivery, we tend to discharge the babies at the 48 or 72 hours. And it is now recommended that we should get a pre-discharge bilirubin level, maybe at 48 or 72 hours. And early discharge babies must be called back after 48 hours. This is an important point to remember. And if those who cannot come for follow-up, we probably should delay the discharge if the bilirubin levels are nearing the phototherapy levels as per the chart. That is number one. Then Amit already said that in the first 72 hours, we should take always the total serum bilirubin. We should not minus from the total bilirubin. Then they also use the term escalation of care. That is, and we have to use the charts, of course, for starting phototherapy as well as for exchange transfusion. But I would say that there are some rough guidelines, not very strictly, but I'm sure that is handy for people. Within the first 24 hours, bilirubin 10 is for more than 35 weeks, of course, is definitely indication for starting phototherapy. Maybe by about 48 hours, I would say 13, and 72 hours and above, maybe 15, and 96 hours, maybe 18. So these rough cutoffs are there if you don't have the charts handy, which is useful for you to remember. Then do we do a serum albumin routinely? Amit said that if the serum albumin is less than 3, that is a high risk for neurotoxicity. So probably the latest guidelines say that even if you're thinking of escalating the care, like, you have to go for an exchange transfusion. At that level, it is definitely recommended that you must also get the serum albumin done. Then the risk assessment and monitoring is again very important. And as Amit rightly pointed out, one of the important risk factors is the gestational age. So as the gestational age goes down from 40 weeks, with each week down, the risk of the risk of the jaundice, risk of the hyperbilirubinemia increases. That is very important. That is why the gestation becomes a very important factor. Then any jaundice within 24 hours, of course, is pathological. And if your pre-discharge serum bilirubin is close to phototherapy levels, you should be careful when you discharge such a baby. Then if you're thinking of hemolysis due to any cause, like for example, if the bilirubin is rising, the rise of bilirubin per day is also important. That is, if you have a rise of more than 0.3 milligram percent per hour for the first 24 hours, or more than 0.2 milligram per deciliter per hour for the next after 24 hours. Then if for those babies who have who were requiring phototherapy before discharge, you should be careful, because sometimes if it is because of some hemolytic cause, may have rebound hyperbilirubinemia. Then if you have family history, like if you have, especially in, I would say in ABO, like if the ABO, usually the first baby gets affected, but then if there is a family history that, the previous baby also got phototherapy and previous baby also had jaundice, we should be careful about such babies. Then those babies with, of course, cephalomatomas, Down syndromes, infant of diabetic mothers, these are again the babies whom we need to be careful about phototherapy. So these were some of the things I wanted to add. So Amit, I wanted to know whether any update on the new guidelines from Indian NNF has done after 2020.
No, this is the recent 2020.
Yeah.
Dr.
Because
Amit, can you stop sharing the screen?
Yeah,
American
sure.
Academy has come out with the 2022 guidelines now, no?
Yeah.
And what about that?
See,
Are we making it mandatory pre-discharge bilirubin?
Not, see, ma'am, this guideline is for managing, but as you rightly pointed out, it has always been advised that before discharge, if you have TCB, then TCB, otherwise serum bilirubin, and put them there. AAP has a different chart for discharge. Now, this is those baby who are not under lights and who we are discharging. Now, that chart has a low risk, low intermediate, high intermediate, and high risk. Now, as per that, they have a time for follow-up. Now, in a low risk, you can call them back somewhere 72 hours to 5 days. In a low intermediate, you will call them back in 48 hours. In high intermediate, you might call them back in 24 hours. And in high risk, in 6 to 12 hours. So, practically, if your patient lies in somewhere between a high intermediate and high risk, don't send him home and monitor him in the hospital and start phototherapy. In the low risk, you can tell them. So it is a very good thing because we always say chronic stress is all or none. So chronic stress should not happen. It's a preventable morbidity. It's a preventable cause of cerebral palsy. And it's a very bad cerebral palsy. So we can avoid that by doing this discharge charting. These charts are there available in all neonatology textbooks, and it's available online on the AP site also, or if you put just in Google discharge levels. Here, once again the same thing, level, age in hours, but it's slightly different because it has a low, intermediate, and high, and intermediate is once again divided into low, intermediate, high. But that is a very good culture to see that we are putting them and telling, advising them objectively that when to come back.
Okay. I want to add two more things for the postgraduates. Always remember to assess jaundice twice day, at least 12 hourly for all newborn babies. That's why we make it a point to have 2 rounds, morning rounds, evening rounds. Once they pick up, see, this is simple. Sometimes you pick up a baby from the postnatal ward and suddenly the bilirubin is already gone up to 20 or 18. So I think our vigilance and our monitoring isn't good. And you must remember there is a very strong association of exclusive breastfeeding and jaundice. So when you exclusively breastfeed, as he said, it is the breastfeeding jaundice. If you feel that the mother is not feeding enough, adequate, less than 8 feeds per day for that matter, you should be careful. In India, we breastfeed exclusively most of the babies. So we should be watchful for breastfeeding jaundice in the first few hours. And one more question for the PGs. Do you recommend to give water, dextrose? I've seen this practice being done when the babies are on exclusive breastfeeding, when they get jaundice. You don't need to give IV fluid, but I hope nobody does it. It is a strict no. There is no need to give any oral water or dextrose when the babies get jaundiced. But then assessing the baby 12-hourly, looking for jaundice is very important.
I'll just add one thing, and as Madam said, assess them twice a day and assess them in daylight.
Yes, correct.
Not under our tubes. Currently, we all have fluorescent tubes. Under fluorescent, we see everything exaggerated. The babies look more yellow, more red, more blue, whatever. So always have a good practice going to close to the window or go outside and see the babies, assess the babies. When you are assessing clinically, with TCB, it's very simple. You can just have transcriptable bilirubinometry and you get the level. But as Madam said, it is all about the vigilance. See, that's why we are putting them in hours. We are not saying in days, 2-day baby, 3-day baby, 4 days baby. So it is a more of monitoring and early intervention. As we already said, it's all or none phenomenon. We don't want any baby to develop chronic in the society.
One more thing, how long can the breast milk jaundice last? Many times when they come at 4th week of life also, they're still jaundiced. We know the stool is not pale. We know we have already ruled out. We are not talking about the stool cut test and what is conjugated bilirubinemia, but I'm talking about indirect hyperbilirubinemia lasting beyond 3 and 4 weeks. We see
we can accept it for 6 to 10 weeks unless they are in pathological level or it's a direct jaundice. So we all know that beyond 12 days to 2 weeks, usually the bilirubin doesn't cross the blood-brain barrier as it matures, and it won't be a damaging thing. So we just monitor. So like a bilirubin of 18 or 19 on day 15, day 16 may not need any treatment because it's not going to damage the brain. And it may remain for almost 6 weeks to 10 weeks. We just need to keep on monitoring and we need to see that it remains indirect jaundice and it is not rising very fast. But the only thing is, whenever we are having this prolonged jaundice, we should rule out all the risk factors like hypothyroidism, any causes of hemolysis, or weight loss, hypernatremia. So all these things, or any sepsis, UTI, all these things can present with prolonged jaundice. So we have to rule out all those sicknesses, and if everything is fine, then we can easily accept, because as we all know, the enzymatic system of liver will mature completely by 6 to 12 weeks. So it might take that much of time to completely become completely disappear from blood.
Also never miss out Krigler-Nager. We may not think, but then prolonged indirect Krigler-Nager and Gilbert's.
Sometimes type 2 Krigler-Nager may remain like that. Type 1 usually is diagnosed in.
Yeah. Again, about transcutaneous bilirubin, it has become, actually, it decreases your sampling. It is good. But as Amit rightly said, in preterm babies and those under phototherapy, and also it doesn't fare very well at high bilirubin levels, I think. When the bilirubin is above 15, 16, probably you need to confirm it with serum bilirubins. And always before phototherapy and before going for any other treatment, escalating your treatment, definitely serum confirmation is important, bilirubin.
Absolutely.
Yes. There are more queries actually. How much chances of rebound of hyperbilirubinemia again?
See, rebound is always a chance when we have higher bilirubin levels initially. See, always there is some rebound. because as we discussed, phototherapy is like isomerization. It will just liquefy that bilirubin and it will help in excretion. Now, that part of bilirubin that remains bound to adipose tissues, that will come into picture only when this bilirubin goes out. So rebound will happen when we have higher amount of bilirubin, which reflects as a higher level of bilirubin in blood. So higher the bilirubin level, higher the chance of rebound. Lower the bilirubin level, lower the chance of rebound. And when we talk of rebound, it's the acuity of rebound. So how much high it will go. So that will be less pathogenic if it is a lower level.
Okay. One more question, sir. In LED-based phototherapy, are there chances of dehydration?
See, LED based is a cool light. The problem was more with halogen phototherapy, which are not there in picture now. It was even with the tube-based phototherapies where sometimes it used to cause heating. Now LEDs are cool. It's a cool light. So there will be, that's why with the LEDs now, when we had these old halogen phototherapies, the minimum distance was 45 centimeters. Now with these LEDs, we take the phototherapy as close as possible to increase the dose because it is not going to heat. So dehydration and all those things won't happen with LED photo. That's it. The only thing is you just keep on monitoring the dose.
So would you like to prefer matrices and fiber optic pads for bilirubin, after bilirubin?
LED phototherapy is better. See, fiber optic pad, the problem once again is we all know the physics. The light travels straight. In a fiber optic pad, if we start molding it, there will be loss of ultimate dose of bilirubin. And that's why fiber optic pads are not that famous nowadays. Initially, when they came, even we thought of wrapping the whole baby in a fiber optic pad, small baby, 1 kilo, 1.5 kilo baby, could be completely wrapped in a fiber optic pad, and then it will cover the whole surface area. But it doesn't work that way because light, by physics, law of physics, light travels straight. So the more mold, more loss of this. And that's why we have these LEDs and all of these come straight on the baby. So direct higher dose will fall on the baby's surface.
Yeah. Last questions, few more questions. When should we stop phototherapy and switch to the exchange transfusion? Shortly, it is like just tell us please.
Can you
Before we
repeat
start that,
that?
when to stop phototherapy and immediately give exchange transfusion? At what level? The PG student wants to know this.
See, the idea is we don't stop phototherapy when we do exchange. We continue phototherapy. See,
When
by
to switch?
exchange,
I think Amit, he wants to know when do you escalate?
to exchange.
When do you escalate the therapy
okay,
from phototherapy to exchange?
See, whenever a baby under phototherapy, the bilirubin is rising at more than 0.5 milligrams per hour with phototherapy, or the baby starts giving you neurological features, irritability, arching, bind score. There is something called bind score. So when you see that bind score, then we can start thinking about exchange. Exchange, see, whenever a patient comes close to exchange level, when we are starting phototherapy and starting IVP and all that, that is the time with the first sample we are sending a cross match and keeping the blood ready because this baby at any time may need exchange. It's a good practice not to wait till the baby converges. So phototherapy, continue phototherapy, and if it is rising very quickly and we are seeing some neurological things, we go ahead with exchange.
And also they can use the chart, just like the phototherapy chart,
Yeah,
they have the
absolutely.
levels for exchange transfusion. So they should.
That's why we, like
Before
2
start.
hours, 4 hours, 6 hours, we monitor the bilirubin as per the acuity of hyperbilirubinemia. And if we are rising and closing the exchange, then we go ahead with exchange.
Okay. Sir, during giving the phototherapy, double surface of single surface phototherapy, is it necessary to keep the area with white linen or anything to increase more intensity of phototherapy? Can we use the foil, silver foils and all?
See, the idea is we as any therapy, phototherapy also has a dose. Now the dose of phototherapy depends on the intensity of the LED. So a conventional phototherapy has a dose of 10 and an intense phototherapy has dose of 30 to 50. Now it is the intensity of phototherapy. Then the surface area that is exposed to phototherapy. Now, how will you increase the dose? Now we increase like with one phototherapy, two phototherapy. Here we are just increasing the dose. Now to increase that surface, the dose, what we can do is we either put a white linen, so that reduces the reflection loss and concentrate the dose, or we can, as we normally what we do is we put the aluminum around the bed. Now, what aluminum foil will do is it will reflect water phototherapy is not going directly to the baby and it will come back to the baby, it will increase the dose. The only thing is when we are putting the aluminum foil, it should be plain aluminum. Now, if it is a wrinkled aluminum foil, it will reflect light in all directions and ultimately it won't reach the baby. So, we have a straight plain aluminum foil that will reflect that dose back to the baby and help in increasing the dose of phototherapy. So it is just to increase the dose. So we can do it anyways. You can bring the phototherapy as close to baby as possible. You can put the aluminum foils. You can put a white cloth around that. But the only problem with this white cloth is monitoring becomes very difficult. If you can't see the baby, it's difficult to monitor if anything goes wrong. Or this intensive phototherapy baby convulses or it has an apnea, it becomes very difficult to monitor them with this cover.
Okay. Sir, till what gestation is transcutaneous bilirubin assessment is validated?
At any gestation.
It can be done.
See, conventionally,
But
see, the basic idea is a screening tool. So if we feel clinically the baby is looking yellow, like the Kramer's classification that we had, we feel the baby is looking yellow, we do TCB. Now the TCB shows the level which is around 3 milligrams, close to the therapeutic level, we do the serum bilirubin. So it's a screening tool. You can use at any age.
okay. One more question, sir. Regarding the flux, how to measure? Is it necessary to measure the flux during phototherapy or something like that? Or if it is written 10,000 hours after starting that, getting a new LED, just replace it.
See, there is a flux meter. And the company, if you don't have flux meter, the company guy comes with a flux meter. It's a good practice to check the flux somewhere in 1 year or 2 years. Now, most of the phototherapy units that we have, the LEDs has a life of 50,000 hours. So nowadays, it's a good phototherapy. Now, initially, what used to happen with the tubes? The tubes used to have 6 to 10,000 hours. And that's why we used to measure them at 6,000, 10,000 hours. And 6 tubes. So many times it was a white and alternate with blue. So the dose used to vary. Now with the LED phototherapies, 50,000 hours is a good lifetime, and most of the good phototherapies come with an indicator behind. If you see where you press the button on and off, there it reflects the hours. It's just like ventilator we have working hours. The same way the phototherapy also reflects working hours. So that will guide you about that. At any moment you feel visually that the phototherapy is not that bright, check the flux.
Okay. Any more questions?
I think there was one question. I think there is, Matin, one question that, till what age TCB is reliable? Or beyond what gestation, I think. Below what gestation?
Yes,
Transcutaneous is not reliable.
Below,
I think up to what gestation? There is a question, I think.
Being a screening tool, we can use it at all. Like anything beyond 26 weeks, we can use it. See, the issue with transcutaneous bilirubinometry is the thinner the skin, better it is. The problem will happen. We initially used to think when it came that in Indian babies, dark skinned babies, it won't work. And the studies were done in India which showed that it is the more the thickness, less reliable it is. Lesser the thickness, more effective it is. So TCB is more reliable in a less pigmented, thin skin. It's not that much reliable. That was the thought that it won't be reliable in a melanotic patient. But in Indian, even in the African population also, it has been found effective. But always keep in mind, it's a screening tool. So it is just a screening. Visually, you see it is yellow, screen it.
Okay. So can you recommend to LED phototherapy unit any company, not any good companies? Would you like to with good less maintenance?
There are
Anyway,
quite a few good companies, Indian companies and foreign companies. It's nothing to recommend. It's always all companies are producing good LEDs. So we don't need to talk about any company. On such a platform, we should not tell about any company. But all the companies, I have Indian phototherapies, I have foreign phototherapies, all of them are working well. Just be a, see, always any rule for any equipment buy is the guy from whom you are buying, you should have a good rapport. If anything goes wrong, he should come back to you. Now you want to check the flux of the phototherapy, he should come with flux meter. He will not say, okay, we'll come next month. So always you have friends around, buy the same company all together, so you get a better service. It all depends on the post sales service. So all phototherapy is good.
Okay. Sir, can transcutaneous bilirubin be used in the age of 50 weeks of post-conception age?
What is need?
What, sir?
Why it is needed? 50 weeks. No, that's what I'm saying. Somebody who is beyond 2 weeks of chronological age doesn't have any risk of encephalopathy. Why you want to do? You can do. Nothing harm, but it's not needed. Somebody is born at 38 weeks. After 12 weeks, he becomes 50 weeks. But 12 weeks, even at 40 weeks, there is no risk for a 38 week.
Yes. Okay. Yes. Okay, sir. I think all the questions and queries have been answered. Yes. Sir, as you are already published, you're a co-author of neonatal parental nutrition guidelines. You are published or a co-author. Would you like to add just a few words regarding topic? Not the topic, but still you are the co-author for that. So would you like to enlarge in some words, important words? Please, only few important points, please, because there are pieces also.
Basic thing, always keep in mind. If we are running a unit which is level 2 and above, if I am ventilating a patient, if I am putting the patient on CPAP, if I am managing a less than 1.5 kilo baby, I should have facility of parenteral nutrition in my unit. It is as important as ventilation. Our problem is in India, nutrition has always been neglected at all ages. So parenteral nutrition is critical for those babies whom we can't feed for first 3 to 5 days, at least reaching 50% of volume. So any baby who is a surgical baby, any baby who is less than 32 weeks and is not going to be fed at least 50% in first 3 days, any baby who is around 35 weeks and not fed for at least 50% volume in 5 days needs parenteral nutrition. At least start partial parenteral nutrition, which is dextrose protein. And in that case, you can start feeding early and you can get off. Or if a sick baby, full parenteral nutrition, that is also decreased. Now we have published a good study in Indian Pediatrics in 2012, where we have shown that less than 1500 grams sick babies in India, aggressive parenteral nutrition at the dose of 3 grams of proteins and 3 grams of lipid is safe. That is published 12 years back. So in India, it is safe. And if we are managing sick babies, we should have a facility of parenteral nutrition.
Okay. Thank you so much, sir. there are all the questions have been answered.
No, no,
Very well
Bhavesh
done.
wants to.
Matin, if you allow me
Matin,
to ask
Bhavesh.
one more last
Yes.
question.
Yes, sir. Please, sir.
Okay. This question is regarding to the previous question's continuation. And so in a situation where we have a prolonged jaundice because of either an RH incompatibility or maybe a possible breast milk jaundice in a baby otherwise who is stable, and we need to just monitor them because the jaundice may persist, indirect hyperbilirubinemia may persist for 6 weeks or 8 weeks. The question was that instead of doing a serum bilirubin frequently once in a week or once in a couple of weeks, can we use a transcutaneous bilirubinometer to monitor that level so we avoid the prick? That was a relevance of the question of the previous one, that what is the gestation age till we can use the transcutaneous bilirubinometer? Question to both the experts.
Sir, the thing is, now in hemolysis, immune hemolysis, like RH incompatible, ABO incompatible, the thing is the hemolysis will remain there for almost 12 weeks. And beyond 2 weeks, what matters most is anemia than jaundice. Now, what is a potentially fatal problem in continuous hemolysis is anemia. So we have to monitor his hemoglobin, because these are the babies who may need transfusion in first 3 months of life, because the hemolysis will continue. Now in hemolytic, this is like RH incompatible, ABO incompatible, we start with good phototherapies and we monitor the bilirubin. And if you don't monitor the hemoglobin, it is the anemia that kills the baby. It is not the jaundice that will kill the baby, because we have good phototherapies. So those babies die of acidosis and anemia, not jaundice. So in such a patient where we feel that he is having higher levels of bilirubin, this is a baby who will have a more severe anemia. And there is no way of diagnosing anemia non-invasive. So in these patients, we have to check their hemoglobin. Now, bilirubin can be measured up to 50 weeks. We can measure by transcutaneous bilirubin meter. But once again, it's a screening tool. Now, here we need to monitor their hemoglobin. And that's what we counsel them at discharge. See, the bilirubin is taken care of, and your baby, because the antibodies remain in the body, and they will remain there, as we all know, IgG, it will remain there for 3 months. So for 3 months, this IgG at some dose will keep on causing hemolysis. And these are the babies where we need to check the anemia. So if you feel that he is sick enough to have higher bilirubin levels, that indicates that he is having severe hemolysis. And in severe hemolysis, we need to check hemoglobin, because the only treatment will be transfusion in.
Hello.
I think Amit, what is asked is that, see, in transcutaneous,
Not sick child.
we are
In a
not
not sick
measuring
child.
the bilirubin. We are not measuring the bilirubin.
Transcutaneous can be used
No,
up to 12,
no,
up
that's
to
what.
8 weeks.
In transcutaneous, we are not measuring the bilirubin. It is the yellowness of the skin which is reflected and the light it is picking up. So what I think Dr. Bhavesh's question is that when the baby comes at the age of 6 weeks, because all the studies are in up to 40 weeks, maybe 40 weeks of this thing. After that, I don't think when they come with the prolonged jaundice, maybe at 2 and 3 weeks, whether instead of doing a serum bilirubin, can I go for a transcutaneous bilirubin? That's what your question is.
Absolutely,
so I don't know
that's the
whether any
question.
studies are there.
Practically,
Yeah. So that is why the skin,
practically we
maybe the
may,
skin
but it is
thickness and the skin thickness and other things which comes into play there, whether it will actually reflect the true bilirubin level or not.
practically we may, but I need to find out, because
That's why I also
to be
don't know
frank,
whether
I
any
never
studies
thought of
that
this thing.
40
Because
weeks.
see, as a neonatologist, what we think when it comes to jaundice in a hemolytic is anemia. So I
That
really
is there,
don't
but
know the answer.
I
I'll
think
check
his
and let
question
you know.
was, his question was in measuring bilirubin specifically.
Yeah.
I think that was
What I
If
can
I
do,
may-
I have Bhavesh's number. I will check it and get back to you, sir.
I'll tell you the reason behind this question, because recently I had a child who otherwise was full term and was discharged and no any RH or bio incompatibility, continued to have a prolonged jaundice to the level around 14, 15, lingering on for almost 4 weeks. And it was looking like other causes were being ruled out, and it was looking like typically a breast milk jaundice, obviously diagnosis of exclusion. Now these parents will keep coming every week and say that machine se check karke de do. The question is, do we really have? Baby is absolutely fine, thriving well, feeding well, passing urine well, passing stools well, stool colors are fine. There is no evidence of any direct hyperbilirubinemia. The parents were most insistent for checking with the TCB machine. Now, even I could not find any study to say that beyond what age we can use this to monitor clinically. So, in a non-hemolytic setting.
Yeah, that's why I said I also don't know. I'll check it and get back to you.
Okay. Yes.
Yes,
So I
Matin.
think all the questions have been answered, and the experts have already done very well, and all the queries are solved except one. We'll search, and Dr. Tagarsa will give the details again. With permission of our president, sir, could we conclude, or are there any?
Yes, you
any
can
remarks?
conclude.
Yes. Okay. I'd like to thank Dr. Ram Gopal sir for taking the initiative of protocols on PRC with this protocol of IIT Action Plan 2024. I'd like to thank Dr. Amul sir for being a source of energy like mitochondria. I'd also like to thank our OBs and EBs of MahaIP. I'd like to thank Dr. Sarah Dhanode madam and Dr. Amit Sagare sir for giving excellent knowledge, practical knowledge. I'd like to thank our Mrs. Pallavi madam, who's from DIIP, and she takes care of all the technical Zoom meeting technical support. I'd like to also thank Dr. Vishal Raut, who's our digital wizard who plans and takes this Zoom meeting in. And I would like to also thank all the delegates who have patiently waited here, and I'd like to conclude the session. We'll be meeting again. Yes.
Yeah,
Okay.
we will meet on 15th for the Wednesday wisdom.
Yes.
Okay.
Okay. Thank you.